thank you everyone for joining us tonight. It's great to have everyone, and hopefully you all learned something.
So we have about 350 people signed up, so we can't do Zoom with verbal back and forth. And so what we're going to do now is go to our PowerPoint slides, which are kind of going to be in the background for the first half of this session. So Julianne, could you go to the PowerPoint slides? And in that regard, I want to introduce our two helpers that do the lion's share of work behind the scenes. And that's Julianne Frame here, and she might just pop in and just say a quick hello. And Sarah Kerslake, who's run research for our foundation at Banff Sport Medicine for many, many years, have really helped to make this work. So that's the crew, and we're gonna do this via two platforms. One is through Zoom, and then one is a live feed through Facebook. So either of those are gonna work. We wanna have some interaction. We wanna make it casual and fun. So we're gonna have sort of two separate sections. The first section is question and answer about knee injuries, knee pain, osteoarthritis, and skiing with knees. And then the second half is going to be some exercises. We're going to get on the floor doing planks and bridges, and Lynne's going to give me a workout. And so I hope people are prepared to do some exercises. And if not, we, definitely find some time to get on some shorts and some runners, and we can do some exercises. To communicate with us, we're going to ask that you use the chat function on the Zoom. And on Facebook, Julianne, is there a chat function? They're just going to type in on Facebook so that we can get questions. And we will stop after slides and answer questions. So that's the format. I think we should roll along. Got a little something in the screen there that might be blocking you.
I'm just going to try again.
Technology is working with us again. We froze on our first slide, so we'll see how we're doing. All right. So go on to the next slide, and then the next slide.
Okay, so we're going to be asking some questions, and we'll give you a couple of seconds to try to answer the question in your own mind, and then we'll give you the answer. So the first question is, how many cruciate ligaments are in the knee? 1, 2, 3, or 4?
All right, do you want to advance the slide there? So the answer is B, and we thought we'd start with just a little bit of anatomy of the knee. In an evolutionary sense, the knee was not designed to ski, and it's a bipedal beast where there are 4 main structures protecting the knee, and most of them are linear. In the middle of the knee lie 2 cruciate ligaments. The anterior cruciate goes from the front of the tibia to the back of the femur, and the posterior cruciate goes from the back of the tibia up to the femur. Those prevent anterior translation in the ACL. That's what the check rein is for the ACL, is to prevent anterior translation, and the PCL is to prevent posterior translation. So imagine skiing in the back seat, and you suddenly contract your quads and the tibia goes forward. That's how you tear an ACL in one of those modes. You can also see that the cruciates are in the middle of the knee, and so rotationally they are very ineffective, and they don't have a good rotational function. Hence, all the twisting sports, soccer, ultimate, and catching an edge skiing or catching an alder powder skiing, those are all mechanisms of tearing the ACL. Then, for completeness, we have 2 collateral ligaments on the outside of the knee is the lateral collateral, and on the inside of the knee is the medial collateral, and they get sprained when the knee is torqued sideways. So that's sort of the basic anatomy of the ligaments of the knee. In between are two meniscuses, and you can see that better on the picture on the slide. And those meniscuses are cushions, and they can also get torn with twisting, and specifically they get torn once you've torn your anterior cruciate ligament. So that's sort of the backdrop of anatomy for us to go forward.
Okay, how common is it to tear an ACL in skiing? Is it 1 in 100 ski days, so 1%, 1 in 1,000, 1 in 10,000, or 1 in 100,000?
But while you're thinking of the answer to this question, think about how many of you know someone who has torn their ACL or have torn their ACL themselves. So that could help with the answer. Next slide. So the answer is B. Tearing an ACL skiing is about 0.1%. So it's actually relatively uncommon in one sense, but common enough. If you ski 1,000 days, there's a chance you're going to tear your ACL. The funny thing is it's not distributed equally across the population. We know that there are risk factors for tearing the ACL. There's certain shapes of knees, the knock knee, the weakness around the knee, the environment you're skiing in. When you get to a national ski team level, there's almost a 50% ACL tear rate in that group. So there's definitely, it's not, oh, I ski 1,000 days, I'm gonna tear my ACL, so I'm gonna stop skiing at 1,000 days after 10 years or 15 years. It's more complicated than that, but it's frequent enough. Another way to put it in perspective, on a busy spring skiing day in the Bow Valley, there's about 14,000 skiers out. 14 ACLs will be torn on that day. Not all of them need surgery, not all of them will be bad, but that's a fairly high incidence a day when you think of a busy ski day.
What do you think the most common mechanism of an ACL tear is while skiing? Is it one of those really slow twisting turns? Is it a high velocity crash where you yard sail all the way down the hill and lose all of your equipment? Is it landing a jump in the back seat? And the back seat means that you're sitting way, way back and your quads have to really contract super hard to keep you upright? Or is it running into a tree with your knee? What do you think is the most common?
Well, the answer is a yard sail can tear your ACL as well as the back seat. But from a history point of view, in patients we see that tear their ACL in the emergency department as well as in our offices, it's that slow twisting turn. And even the elite skiers, the coaches and athletes, sometimes you hear them, oh, I was carrying gates down a course and I turned to see someone, and that slow wind up of the knee. So imagine catching an edge, your DINs are at their normal, but you're going low energy, so your ski doesn't pop up, and the knee winds up, and the femur dislocates off the back of the tibia, and you tear that ACL. So the most common is a slow turn. From a PCL perspective, hitting a tree. They go and they hit the tree, and that's what tears the PCL. Yeah.
I'm just going to say that the bigger yard sails is enough force to let you get your bindings off. So you tumble down and you don't necessarily twist your knee, but it's those slower twisting ones nearby. Your skis don't necessarily come off, and then there's a big long lever arm that works your knee. All right, so you've torn your ACL. Is immediate surgery the optimum for a skier to have surgery right away once you've torn your ACL? True or false?
The answer is false. In many instances, it's way better for the knee to settle down, get the swelling out of it, get it moving again, get motion back prior to considering surgery. There's also a number of people that their ACL will heal. And that slow twisting turn in a skier, a good number will actually tighten up and not need surgery. So that instinct of when you're told I have a torn ACL, I need surgery right away, isn't correct. Now, what is correct is you don't want to go out and hurt it a second time. So the knee does settle down in 6 weeks. And then you say, oh, I'm going to go skiing again, or oh, I'm going to play soccer again. That is what causes more damage and you injure your knee again. So you don't need rapid surgery, but you do need to stay linear, ride the bike, do some weights, get the knee to settle down.
Go to physio.
Go to physio, and have a coach.
Have a coach.
Yeah, so that's the truth. It's not a rush into the OR.
Okay, are ACL injuries easy to diagnose, or sometimes are they not easy to diagnose? True or false?
The answer is false. The physical exam of the knee in detecting an ACL is actually moderately difficult. When people hurt themselves, they don't relax. They don't let their muscles go quiet. And so it's difficult for emergency physicians. It's difficult for physiotherapists. It's difficult for surgeons to diagnose an ACL purely on physical exam. What we are trying to get that education out, though, is a high index of suspicion with a mechanism. I had a slow twisting turn at Lake Louise. I felt a pop. I got up. I tried to ski again. I collapsed. All that raises a high index of suspicion. Even in the best of hands, you might not be able to make that diagnosis right off the bat. And it's important to bring the patient back and re-examine them. So ACLs are missed. And if you're in a situation where you're not seeing a lot of ACLs, that reminder of having a high index of suspicion is super important.
And an interesting point just to add is that lots of people, when they tear their ACL, they have acute pain, but then the pain goes away because they've completely torn it. And so they don't really think that they've injured their knee lots of times because there's no more pain. But when we test it, it's quite obvious that it's been torn. ACL tears, true or false? They never heal.
Well, I kind of gave that away in one of the previous slides. My bad, Lynn. I'm giving out marks again. Anyway, in that slow twisting turn, the ACL sort of peels off the femur, and it tends to peel off right against the bone. And you'll get a blood clot in there, and it can heal. And I kind of, in those slow, low energy tears, feel about a third of knees will actually heal and get stable. And I've had, numerous patients over the year. You examine them on the hill, they have definitely a loose knee, and you examine them at 6 to 8 weeks, and their knees tightened. In a general term, it takes about 2 or 3 months for an ACL to heal if it's going to heal. So even if the knee feels better at 6 weeks, I would definitely give a knee a minimum of 3 months to see if it'll tighten up. If you feel you want to go, or if it has some characteristics that says this might be one that'll heal.
Some skiers can cope with a completely ACL deficient knee. An ACL deficient meaning that it's been torn or it's stretched enough that it's really not holding the stability anymore. Is that true or false?
Surprisingly, skiing is one of those sports where 90% of the time, when everything's linear and you're on your skis, that you don't need an ACL. And it's only when you catch an edge or catch an alder or in the back seat that you stress your ACL. So in fact, skiing is one of those sports where people can cope well. I kind of have a rule of thirds. There's a third of people that are going to move on and say, you know what, I'm not going to pursue downhill skiing, or I'm going to brace. I also have a third that they go on and can ski and ski well for years. The only caveat to that is they often have a few tweaks along the way and can end up tearing a meniscus, and they often have an arthritic knee 20 years, 30 years later. In our population, I find about a third say, I love skiing. It's part of my life. I want to be back out there in the mountains in the sunshine and pursue surgical correction. Body type, body anatomy, all those sorts of things help us give you patients advice about whether you're a good design to be a coper. Those that are super stretchy and can bend their fingers back and double jointed at the elbows and knock knee are more likely not going to be a coper than the guy like myself where touching my toes is about like that, and you have sort of a big build. They tend to be better copers. So the answer is yes, there are many skiers skiing without ACLs out there.
Yeah, we're going to talk a little bit of a case study. A friend of ours, she's a super fit female in Canmore, and she was skiing at Lake Louise, twisted her knee, felt the pop, had swelling, examined by a physio. So we do a test where we call it the Lockman test, where we test the knee, and it was very, very loose on testing. And she got referred to Dr. Hurd, and he agreed it was very, very loose on testing. And then she went on to have an MRI, and the MRI confirmed that it was a completely torn ACL. But she surprisingly was able to go on and run and bike and mountain bike and ski, even without a brace, and she's had no symptoms and no instability. So it's interesting that some people like her can really cope and can choose at this time not to have surgery and continue to ski, whereas we can have some of the strongest, most amazing fit alpine ski racers, and they tear their ACL, but their knee just gives out every time they make a turn. So it's not always just fitness. It can be, like you said, anatomy, neuromuscular control, just the way that your knee is shaped.
Yeah, so true, Lynn.
Mark, I have a question from the audience.
Right.
So the question is the concern for arthritis similar for the group who cope and the group that has ACL surgery? Thanks, Fraser.
Fraser, thank you for that question. And it's an awesome question. And the question is, what is the risk of getting osteoarthritis if you have ACL reconstruction or are a coper? Is it higher for the coper or the ACL reconstruction? And it's a fascinating question because there's not a clear answer. The literature over the years have had a lot of these studies that are longitudinal. And one of the big ones is the Scandinavian study done in the Scandinavian countries. And they suggested that at 20 years, people that had surgery had more arthritis than people who were copers. Now, what they didn't tell, what they didn't tell that hit the press, the New England Journal of Medicine, is that people that were symptomatic crossed over to the surgical group. So that made us scratch our head. Oh, the copers that went and had surgery went and had arthritis 20 years later. You also got to go back 20 years from now, where we tended to fix the worst of the worst, the very symptomatic knee, the ones that did have 2, 3, 4 injuries to their knee and tore their meniscus and damaged the lining of the joint. And so they got the reconstructions. And of course, because they had so much damage to their knee, they went on to arthritis. So we strongly feel that if you can fix the ACL surgically before you tear the meniscus, before the second injury, and before you go and have repeated injuries, that we are protecting the knee. Now, there's some evidence in just injuring your knee, just that initial injury bruises the cartilage. Having blood in the knee bruises, and is not healthy for the cells. Having blood and having surgery is not healthy for the cells. So there may be no way of preventing osteoarthritis by having an ACL reconstruction. But we feel if you can prevent the meniscal tears and chondral tears, those knees do much better. And one of our major longitudinal studies at our foundation in Banff Sport Med Research is looking at knees 10 years ago, 15 years ago, that didn't have meniscal or cartilage tears and seeing if they have signs of arthritis or not. So we cannot adamantly state fixing an ACL prevents arthritis, but we believe fixing an ACL gives you the quality of life to go skiing and play soccer. And if you can prevent the meniscal tears and cartilage damage, then we think we are also protecting the knee and doing some prevention of arthritis. So I made a very excellent question, lengthy, but the answer is that is at the heart of ongoing research in multiple centers around the world. So Fraser, excellent question.
Mark, we have another question for you. It's from Terence, and the question is, does the use of a custom brace change outcomes for those who are in the COPER category?
So Terence, good question. And the question was, does the use of a custom brace change the outcome in the coping group? And the answer to that is yes. There are good cadaveric studies where they have a cadaver specimen and cut the ACL and do rotational tests, and then they put a knee brace on. So it truly biomechanically does decrease the rotation in the knee. Secondarily, the brace also gives a proprioceptive feel. It gives feedback to where your knee is in space, and it gives feedback to your brain prior to hurting your knee that there are unhappy stresses. So a brace does help. The limiting feature to a brace, though, is our skin and muscle envelope. If we could bolt the brace to the tibia and femur, I think it would be better. So the truth is you can still damage your ACL with a brace, but it is protective. Not foolproof, but protective. The secret with the brace in skiing is getting one that fits, that you don't have to adjust after every run, and that you get it to be just part of your equipment. It's kind of like when helmets came out. In the 80s and 90s, skiers didn't wear helmets. When you put a helmet on the first time, you said, oh my gosh, this is crazy. And now a helmet is just part of an equipment. It's like the ski boots first day of the year. They feel awkward. 10 days later, the ski boots feel great. And so a brace is a similar thing. I think if you get a brace that fits and you want to be a coper, it's a very good way to go. Anything to add to that?
And I find that some people just feel more comfortable and confident when they have the brace on, and then they're not like hesitant and super worried about their knee. They can actually go out there and just be more confident and ski a bit more aggressively. And if the less worried you are, probably the less chance you're going to re-injure yourself. Okay, the most common reason to have reconstructive surgery is it to prevent arthritis? We've talked a little bit about this already. B is to prevent a second injury and the damage to the meniscus and the articular cartilage. C, is it to return to an unstable knee to pivoting sports and activities? Or D, is it just to relieve pain? It's the most common reason to have surgery, because surgery is a big deal. It takes a year to recover from.
So we kind of went over this answer. We have yet not proven that ACL reconstruction prevents arthritis. And so really the literature suggests you're doing this surgery for quality of life. Do you want to keep skiing? Is your knee symptomatically unstable, or are you worried that it's going to give out? We often have patients that are on the fence that we go, why don't you go test it? Why don't you sort of see how it feels? Maybe not full out, But really fixing the cruciate is for quality of life, and we're hoping to prove that it decreases arthritis, but it hasn't been proven yet. Surgery does not eliminate pain in the knee. If you have discomfort in your knee, it's usually from the meniscal tears, the lesions to the joint, the cartilage damage, and that pain does not get better with just doing an ACL reconstruction. There are definite strategies of getting it better, getting fit, warm up, all the things we're going to talk about in the second half help with pain. But fixing an ACL does not diminish pain in the knee. Now, if you have a symptomatic meniscal tear or a big flap of cartilage, we can reduce pain by solving that problem when you fix the ACL, but not the ACL itself.
There's one other question actually about bracing from Kathy, and she's just asking, there are many types of braces on the market. Do they have any value versus custom braces?
Can you take that, Lynn?
There are lots of very good braces that I've come across, and it seems like it's a little bit dependent on each person. So I'd recommend to try different ones on and to work with a brace fitter. The best thing about getting custom brace is it is 100% fit to your knee and the shape of your knee, but they're fairly expensive, and lots of people can actually do quite well with an off-the-shelf brace if it fits properly and they know how to use it properly and which straps to put what order. So I think there's lots of good braces out there, and I wouldn't just say that everyone had to have a custom brace.
Yeah. I'm going to add to that. We talked about the biomechanical part, and that's where you need a relatively solid brace to do the actual structural protection of the knee. But even a sleeve gives you that proprioceptive part, that where is my knee in space? And many patients say, oh, I just used my sleeve or my $140 sleeve with a hinge, and I'm totally happy with that. And I think if that works for you, that is that's a totally acceptable way. The other thing I will say is if you're an average build and an off-the-shelf brace for $600 fits you, then it's no different than having a custom brace. And so I think it is worthwhile what Lynn said. Go try on their numerous off-the-shelf braces, especially if you don't have insurance and you go, oh, $1,600 for a brace, that's crazy. So there's a whole spectrum. I am totally convinced there is going to be a new generation of bracing that uses some of the energy returning materials. And I'm excited by some of the things I've seen in Europe. So there will be a evolution in bracing and exoskeletons and all of these things coming along. Yeah, so good question.
Okay, question 9. You should not ski with knee osteoarthritis. Is that true or is that false? And that is a very common question. In the Bow Valley, we have a very, very active senior population, and many of them have osteoarthritis. So they often ask, should I ski or not? Am I going to make it worse?
The answer is definitely false. Being active, moving, is the best recipe for having osteoarthritis in whatever joints. And getting outdoors and skiing is being healthy. You've got to do things in moderation. You've got to build with the season, start with part days and lots of stops on runs. But in actual fact, for osteoarthritis, we know motion and being active is definitely the way to go. So I would not go, oh, I've got some arthritis in my knee, I've got to hang up my skis. I'd go the opposite. I am going to be healthier getting out and moving. Yes, you might have to give up your mogul days and taking air and ski jumps and ski a little more powder. Backcountry touring has become so popular, and one of the reasons it's become popular is the baby boomers are finding the motion of climbing is great for your heart, great for your cardio and lungs, and it's also good for an arthritic joint. And then you also don't have the same volume of skiing. it's easier on your body that you're just less runs a day with ski touring. So it's another alternative. And of course, hopefully you're skiing powder.
And just to add, sitting on a chairlift and in the cold with your knees bent, and you sit there, you stand in line, and then you sit on the chairlift, you get to the top, your knee might be a bit stiff and sore. So that's where touring can also be good for that. Question 10, Tylenol 3, Percocet and medications like that are okay to take to mask your knee pain and go skiing. Is that true or false, Mark?
The answer is definitely false. I think in osteoarthritis alone, there is no role for narcotics or synthetic narcotics in the management of that. I am totally comfortable with taking Tylenol or some Advil or Aleve or Naproxen if taken appropriately and you're aware of the risks of getting an ulcer with it. I think using anti-inflammatories and Tylenol to help you through the day is totally appropriate. But I do not recommend you taking a couple of T3s before you go skiing. It does alter your brain. They're very addictive. As you know, we have a tremendous narcotic addiction issue that's come up over the many years. And it's inappropriate to take narcotics in this sort of setting. All right, Lynn, is experiencing anterior knee pain common while skiing? Experiencing anterior knee pain while skiing is A, common, B, only caused by kneecap arthritis, C, treatable, or A and C.
The answer is D. It's very common. It's largely treatable, and there are many causes to get anterior knee pain. Lack of warm-up. Like I said, if you drive in your car, you're sitting, you go out in the cold, you don't warm up at all, and all of a sudden you go and ski really hard. Well, that's hard on the knee, and your little kneecap in the front there is going to pay the price. You could have poor biomechanics, which we're going to talk a little bit about later, which can cause anterior knee pain. If you have really, really tight muscles, there's more compressive forces on the kneecap, and that will give you pain. Muscle imbalance. If you do an activity and you only strengthen some muscles in your body but not the other ones, you get a muscle imbalance, and it can maybe pull your kneecaps out of alignment, or just cause various biomechanical issues that can cause the pain. And also doing too much too fast, not training or doing ski-specific exercises all summer and then going on a week-long ski trip. You're going to have knee pain. So we're going to show you a little later how to hopefully avoid that.
Yeah, and so it is normal and it's common, but we're hopefully going to help in that dilemma with some strategies. Prevention. Which of the following factors, Lynn, are associated with knee injuries? A, equipment, B, diet and hydration, C, fatigue, D, fitness. Is it A and B or all of the above?
Well, it's definitely all of the above. There's lots of all of those factors. If you're not eating properly, you're exhausted, you're dehydrated, those all might add to your just lack of being able to recover from a potential fall. Your muscles might be exhausted, and some little slip on an ice, normally you'd be able to right yourself, but that might send you right down into a crash. DIN settings, make sure your bindings are set properly for your weight and your type of skiing. The boot tilt, and Mark can talk a little bit about that. He was in boots that weren't tilted exactly right for him, and that might be part of the factor that caused his knee injury. Ski shape, some of the newer skis cause more G-forces and they can cause injuries. And preseason fitness, which we're going to talk about a little later.
I truthfully, I went and got a pair of backcountry ski boots, and thinking, oh, powder skiing, you're going to be a little more in the back seat. The tilt of my boot was too vertical, and they had an adjustment at the back to flip it around and forward. So I ask you to go look at your boots, and good powder skiing is still skiing over your skis. and a boot that keeps you straight, or you feel like your skis are getting away on you, check the tilt of your boot. It was something I learned, and I had the factory setting on, and I actually changed it to the more anterior tilt. The other thing I will talk about is this whole hydration idea. There's a scientist down in Cranbrook, Delia Roberts, who did a study at all the ski, or several ski resorts, of all their staff and hydration. You know, the staff are getting out and partying at night, coming into work a little dehydrated. When they diligently hydrated, the incidence of ACL injuries went down considerably. And so that was a good lesson, just staying, getting good nutrition and staying hydrated through the day, and definitely not skiing when you're tired. That's another one. But all of those are factors.
All right, well, just make a little note about making good choices when you're skiing. You want to avoid the factors that you can't always choose them, but when you have an opportunity to choose, try to make the smartest decisions. Try to avoid going when it's really bad light, super bad conditions that might cause you to go over a roll and not see it, or go into a compression and not quite see it, and increase your risk of falling. Time of day, maybe you're really, really stiff in the morning and you get better throughout the day. Well, maybe you should ski later in the day. Or I know some people who have way more energy in the morning and they really peter off in the afternoon, so they should likely choose to ski in the morning. You know, it's good to push yourself, but also if you're exhausted and fatigued and you want to do one more run, that's often the time that people fall and get injured and hurt themselves. And again, ski within your limits, so you don't huck that cliff trying to follow this guy and hurt your knee.
Yeah, the time of day is a good one. I just have a fun story. I used to have a slot in the week where I'd go up to Norquay at first chair on Mystic, and there'd be a group of 60 and above waiting for first chair because they wanted the corduroy.
Yeah.
So knowing the grooming report and knowing what's groomed and getting the early corduroy, there's a little tip on timing of the day. It's kind of fun. Research supports exercise prevention programs to decrease the rate of knee injuries. True or false?
That one's absolutely true. It's been proven over and over by several amazing studies throughout the world in various sports, that if you do a very sport-specific, proper preconditioning, preseason conditioning program, that you can really limit your rate of injury. So the FIFA is a really interesting study that was done by a panel of experts, and they came up with a series of exercises that was strength, balance, agility, a whole bunch of different exercises. And they showed if you do this at least 20 minutes a day, twice a week, you can reduce your chances 30 to 50% of tearing an ACL, that one was specifically. So that's pretty cool. That's pretty good results. There's the PEP program. There's lots of studies on NCAA volleyball, basketball, football, and soccer. The Selkirk College Fit for Snow is the one that Mark alluded to a little earlier. And like I said, preseason ski fitness class is very important.
So we've been talking enough. Let's start doing some exercise. We've got a question from the audience for Sarah.
So Mark asked the question, what is the best biomechanical way to fall if you have time to predict when skiing to avoid breaking, tearing anything, discounting any physical landmarks?
So we got another Mark out there who asked, what's the best biomechanical way to fall to prevent injury? And I think that's an awesome question. And hanging on too long, especially in the back seat, is a way of tearing your ACL. And the guys in Vermont also showed that when you catch an edge and you find yourself going into the back seat and you try and slip forward, well, the tibia slips forward. So I actually think the answer to that is give yourself permission to fall. When things are going awry, let it go. We know in the snowboard community, doing a tuck and roll is a good thing to prevent the wrists and the elbow and the upper extremity injury. In the skier community, I think you got to give yourself permission to land on your bum and do a tumble. So it is split second. It is difficult. But if you have that scenario where you say, I'm hanging on too long, I think you got to give yourself permission to fall.
So you fight too hard, it just might be sometimes the wrong thing.
Yeah. Sarah?
Before we go into exercise, we have one other question. And Jenna was just asking if you could please repeat and clarify, can a complete ACL tear heal too?
So good question. And it depends on how you define complete. You can have a ACL tear right off the femur and it's completely torn and the knee is very lax times 0 and it will heal back down to bone. Or it can heal back down to bone. If you have an in-substance complete tear, so in the middle of the ligament, those have a less healing response and are harder to get to completely heal. No ACL completely heals to normal. So if you're 15 years old and tear your ACL, you got to go, boy, there were some risk factors. This is a 15-year-old who tore their ACL. We're going to look way harder at their risk factors and be a little more stringent to surgery or a little more persuasive to surgery when you're 15. If you played soccer and skied your whole life and then had a weird fall when you're 40, I think there's a stronger role to go, let's see if this knee heals, because biomechanically, athletically, they've had a long history without an ACL tear. So that is another factor that we do. There's so many factors that we do in each patient to look at what's the best choice for the patient. Bottom line is a complete ACL tear can heal, but not to normal. All right, I think we're going to get on to some fitness questions. Oh, sorry, one more question. What are the fundamentals of a preseason ski fitness program? A, strength, balance, agility, biomechanics, and alignment. B, balance, extreme flexibility and strength. Or C, just those good old strong quads and hams. What's the answer, Lynn?
The answer is A. All. You need good strength. You need good balance, agility, proper biomechanics and alignment, and neuromuscular control. If you just focus on your quads, like we used to just do that sit against the wall thing and think you were ready to go skiing, well, how does that help if you're slipping and falling or hit a snow snake, or there's a little kid comes out in front of you? You have to have really good balance, quick movements, proprioception. The other thing, if you have really great strength, but you have terrible biomechanics, which we'll talk about in a bit, that's not going to set you up for success. And then neuromuscular control is kind of a combination of how you control your joints. And if you learn to move really properly and with good alignment and good control, you will probably fall less often and hurt yourself less often. But if you don't have good muscular control, you kind of put yourself at risk.
Yeah. In the preseason, we should all kind of look at what are our strengths and weaknesses. So if you're someone with lots of strength, but you could definitely work on balance and agility, focus a little more on that. If you're someone who is flexible, has good balance and agility, but could use some more strength, you can weigh your preseason more to that. So there's no one recipe for everyone. Oh, one more question. Which muscles are most important for a healthy skier? Quads and hams, core, hips and gluteals, or all of the above?
And it's definitely all of the above. So like I said, you need to have strong quads and hamstrings, glutes, core is really, really important. You need to have strong everything. And if you have weakness in one of the groups, you might put yourself at more risk.
I can't stress how important core and hip strength is for the skier. We have always focused on quads and hamstrings, but control of the axial skeleton comes from the middle of the body.
All right, so we just want to talk briefly on an on-hill ski warm-up to do before you ski. Don't get out of your car, rip straight up to the top of the summit and hammer down the backside. It's a good idea to just, even if you spend 5 minutes doing some warm-ups, put your ski boots on, get outside, and the first one is just to do some running on the spot in your ski boots.
Lynn's gonna put me through a bit of a workup and a warm-up.
Where are your ski boots?
Yeah, I should be wearing ski
Okay,
boots.
then you can hold on to your poles and you can do some just leg swings forward and back. Just a dynamic workout. You want to get your blood pumping, your heart pumping, and get your muscles starting to get warmed up and a little more flexible. Do both legs. You can also do some out to the side. Good. Keeping some really quick squats up and down. Warm up your legs and your knees and your ankles, getting everything nice and flexed and warmed up.
I've got anterior knee pain.
I
Lynn.
can hear it. Can you guys hear that?
I need a warm-up.
Little crunchy.
It is, it's great.
Okay, you can put your foot up. Imagine you have your ski on and you're going to put your foot up with your ski in the snow, and you can just stretch out your hamstrings a little bit, lean forward and get a little bit of a stretch for your glutes and your hamstrings. You can also put your hip in the snow and get a little bit of stretch in the front of your hips and your quads. So if you just stand at the bottom of the hill and do those for 5 minutes, it'll be a good start to your day.
Yeah, I can't stress that just that little social interaction amongst who you're going skiing with and doing a little warm-up as opposed to talking can make a whole difference in your day and just get your blood going. Great tips there on the warm-up.
All right, now there's many, like we said, many great exercises for skiing, but we've kind of picked out the kind of top 8 that are really important to do. So Mark's going to do some of them, and we're going to try to stay apart as much as possible. So the first one we're going to talk about is just a double leg squat. So you want your arms forward, just like you're holding your poles. You want to focus on your alignment so that your knees are going right over your second toe. So,
And I hope you guys are out there with your runners and your shorts on doing this with us. We got a question from Julianne.
Oh, we had a question about how long you should hold the stretches for.
that's a very good question. There's different research on that, but I would say 30 seconds to 60 seconds is most beneficial. More important is the dynamic workout or the dynamic warm-up. When you're out in the cold, you don't really want to focus too much on the prolonged stretching, but the dynamic movements are more important.
And I think just the whole principle of becoming a routine, and even a 15-second stretch to just get your body going is better than none at all.
Right.
Yeah, I think out on a ski hill, even 30 seconds is a long time to do a stretch. Ideally, but I think just doing it. So good question. We have controversy right now because Dr. Reed, one of our sports medicine doctor, just wrote an article about the unnecessary need to stretch. So we have even in amongst our team, we're kind of wrestling about what sport stretching may or may not be helpful to. But I'm going to be honest, I actually think skiing is a sport where suddenly you can be taken past your normal limit, and having a warm-up and doing some stretching is going to prevent injury. So I think there is definitely a role for stretching and skiing.
Okay, just a little bit back to the two-legged squats. So when you do the squats, you want to kind of go like you're sitting on a chair. So you don't want to have your knees really far forward and your pelvis forward like that. Like you're sitting down on a chair, sitting on the toilet. Arms forward. You also want to keep your back in a neutral position. You don't want to flex forward like that or be too arched. But just trying to be in a nice.
What if it
neutral
hurts my knees when I'm going down far? What would you recommend?
Well, that's very common. That's where you need to keep it shallow to start with. Ease into more depth as you warm up. Work towards your quads and your muscles being able to tolerate more depth. There's lots of different exercises to focus on that.
Yeah.
Sometimes some kneecap braces, some taping can help. So yeah, there's lots of.
You know, and the other thing that can start, if you know you get sore with squats and that, sometimes a 5-minute spin on an exercise bike or a 10-minute spin on an exercise bike to get your whole circulation going before your little core program is also helpful. But give yourself permission to stay in the comfort zone. So down 4 and up 4, if that's where you're comfortable, that's great. And then you can test where your limits are. But I don't think I'd force it into pain. That's not the, I wouldn't recommend that. It's okay to have some discomfort, but don't force into pain. And, you know, listen to your body.
Yeah.
Yeah.
Good advice. Okay, next is the one-legged squat. Super important because skiing, a lot of times you are on one leg, so you want to keep your pelvis level, no twisting or dropping. When you bend down, your kneecap should be going right over the center of your foot. So you want everything really nice and stable. You don't want your knee to come into a knock-knee position or to go really bow-legged, but try to keep as square as possible. You should feel your glutes working, your quads working. Not bad, Mark.
About how many should I do?
Well, again, if you're just starting it out, probably 1 set of 10 might be enough. But as you progress, if you want to ski hard all day, you should be able to do about 50 of those easily in a row.
Yeah. Any rule for doing sets of them? Coming back.
Yeah, if you're starting to have pain, it might be a good idea to stop when you get that pain, take a little rest, do the other side, and then build up towards to be able to do more numbers.
I had a little trouble with balance. Is it okay to grab some ski poles to do these exercises?
Initially, yes, but long term, you want to get rid of them because you really don't want to be focusing on holding on to something. You really want your body to do the work.
Okay.
Yeah.
So that'll make me engage my core better and work on my balance.
Right.
What if you're really good at this? Is there anything you can do to make it more difficult?
Oh, yeah. Are you really good at it?
We'll see.
So you can go onto a BOSU, onto a balance board. You can go onto unstable surfaces. There's lots of different ways to make one-legged squat harder.
You can close your eyes.
Close your eyes.
I'm not that good.
And initially, like you said, you want to do it very slowly, but as you get better too, you can do a quick drop, very slow up, quick drop, because that is, if you're going off a jump, you need to land very, very quickly and learn to do eccentric motion. You can practice drop.
And so the whole point of this is, even though these exercises seem relatively straightforward, you can have a continuum of difficulty from very simple to fairly challenging. And we challenge you guys to find your limits and be creative.
Right, for sure. All right, the next one is lunges. So a little more dynamic of an exercise is going forward and back into a lunge. And if you listen, you can hear Mark's knees and a little bit of mine. So you want to, again, keep good alignment with your knee going over the center of your foot, going from the side. You don't want your knee to go super far forward. That's hard on the kneecap as well. So more dropping down into like a telemark on a turn, like that. And this one you can make it harder by just going more and more quicker, or you can go on to BOSU. Pushing off.
Let's move this back so we can see. Go ahead, Lynn.
Go onto it and push back.
And so you can actually do enough reps that you can get a little cardio going as well, if you choose to do these things, and get a bunch of reps. And so be creative with that as well.
Okay, the next exercise, like I said, skiing is very, very eccentric. Eccentric meaning your muscles are lengthening and you're having to control your muscles as they go down. So doing a jump down. So Mark's going to demonstrate a two-legged jump down, 2-foot takeoff.
Trying to keep our COVID distance. We have to keep reminding ourselves.
Okay, so he's going to demonstrate a couple not so good ones. So did anyone see there what was wrong? Big knock-knee or valgus position, knees are coming together. That puts your knee into an internally rotated position, and it's a really bad position for ACLs. So lots of people can tear their ACL doing that. Good one. So you want to train your body in a controlled environment to work in good alignment so that when you have unexpected situations, it might just, hopefully your body will just do it naturally. Now you can do a 2-foot takeoff, 1-foot land. Watch your alignment. No wiggling.
Yeah, and it looks easier than it is.
Good.
Stick the landing.
So you start with a small step and progress to a higher one, higher one, higher one. Like the ski racers, when they do jumps, they're literally doing something, off this height, and they're doing a really, and because they're jumping 40, 50 feet. So it's a progression though. You wouldn't want to jump right away on this height. You're going to have anterior knee pain. So progress from this one's about 6 inches, and you're just going to slowly increase up.
Lynn, I can tell already I need some work on this prior to hitting the hill. It's funny, I've been doing these when we do our knee testing, but I've taken a holiday during COVID, and
Doesn't take long to lose.
I can work on some balance.
Yeah.
And then the last one?
1-foot takeoff, 1-foot land. That was good. And then you can also add jump down, land, and jump up. Immediately jump up. Yeah. So there's all sorts of versions that you can do. Right now we're starting very straightforward and very linear, but you can start doing side-to-side jumps as well.
All right, I feel better already. Honestly, just doing a few minutes of these exercises, my anterior knee pain is gone. And I started out with some on the very first few things, so even a warm-up was good.
We talked earlier about hip strength being so important for your knees. And so something super easy is to put some tubing around your, just above your knees. And you're just gonna walk like that, side to side, and you're just activating your hip abductors, trying to stay in good alignment. And then you can also go forward like that, and you'll really feel your hips working back and forth, and then you can go into some jumping. That adds a really good resistance to your hip muscles.
Where can someone get this rubber tubing?
Roughly on Rehab and Sports Medicine Clinic. All physio clinics, probably most pharmacies have them.
Yeah, and it honestly is, $1 a foot or $2 a foot. It's not inexpensive to get the rubber tubing. They are color coordinated, so I think the yellows are the least resistant, going to green to red
Yellow,
to
red,
black.
green, blue, black.
Well, there we go.
Yeah.
Yellow, red, green, blue, black. So I was fairly close on that one. Yeah, so I think it's a worthwhile investment. And you can, not only can you use it in the knees, you can definitely use it for rotator cuff. Us skiers, with a little bit of rotator cuff pathology, I had a fall last year on a glacier, and I'm still wrestling through it, doing a little rotator cuff work. The rubber tubing works great.
All right, Mark's going to demonstrate the plank first of all. So forward plank. So get your bum down, body straight. You want to keep your core tight. Hope everyone can see that. Yeah, you want to keep your glutes tight, your core neutral spine, so you don't want to be too arched or sag down. You don't want to be too high, and keeping your head in a neutral position.
What if I find this hard, Lynn? What can I do to make it easier?
You can drop onto your elbows and or your knees. Yeah.
Oh, I'm liking this.
Yeah, and then you can also do a one-sided plank. Go to your side on one arm, and this really works the shoulder stabilizers in the core and your obliques. And to make it easier, you go on your elbow. To make it harder, you go right up in your hand. Yeah, so lots of versions. You can move your arms, you can abduct your leg at the same time. Always trying to keep a nice, good alignment and a tight core. Not bad.
There we go.
All right, and the last one we're going to demonstrate is lay on your back, head at that end, feet on the ball. Feet on the ball there, and you're going to lift your hips up, go into a bridge with straight legs, and then trying to bend your knees up and bring the ball towards you. And I like this exercise because it's a good combination of core, hamstrings, glutes. And you can, if you're just starting out, hands resting gently on the floor, but as you get better, you can cross your arms across your chest, and so you just have less points of contact on the ground.
Whoa, Nelly.
Yes.
What if you don't have a ball? How can I modify this?
You can put your feet up on a chair or the couch. It's not as wobbly, but it can certainly still make it a little harder. So feet up on the couch.
I have a variation at home where I just do a bridge and
Yeah, that's a great one.
put my leg out to the side because I don't have a ball. And I do sets of 5 as part of my
Yeah, that's a great
7-minute morning workout.
That's a great exercise to do for sure.
So that's one you can do the same without the ball.
Yeah.
Ah, I think I'm going to sleep well tonight. Anything more?
Well, I think those are kind of the basics of the exercises.
So if you're in preseason, what sort of time commitment would you make during a week? How often would you do these?
I'd say start at least 6 to 8 weeks before you plan to ski. So in early October is a good time. And at least twice, maybe 3 times is even better per week. And if you do like a 1-hour session 3 times a week and mixing up all these exercises, combining your strength, your agility, proprioception, balance, flexibility, agility, all those things together, you'll be much better off.
Okay, the hills are open now. We've presented this. What are your final tips for those wanting to go out and get skiing?
Get your fitness up, get your equipment in perfect shape for you. Don't push it too hard initially during the season, and go with friends that are your level so that you're not trying to keep up with your 19-year-old son. And yeah, have fun out there. We hope none of you do get an injury, but if you do, there's many people that hurt their knees skiing, and that's why physios and surgeons and sport medicine doctors are here to help you. Where everybody's situation is different, so we're here to work through your specific injury, your goals, your fitness ability, and yeah, lots can be done if you do hurt your knee.
Yeah, and I can't reiterate, start in small doses. It's okay to ski a half day. It's okay to ski 2 or 3 runs to get going. And stay hydrated, nutrition, all those multi-factors we've talked about. And as you know, most of you out there are probably passionate skiers, and all the little things add together to make you a safer skier. We have time for questions.
So we do have another question. So Lynn, if someone's had meniscal surgery, do you recommend that they ski without poles to help with their hip and knee strength as a strategy?
I wouldn't necessarily say ski without poles. I would say the preseason fitness is very important, and working with a physio or a trainer who has a lot of knowledge in this area. You could maybe do a few drills without poles to make sure that your balance and your technique is good, and that maybe you're not relying on your poles every turn. But I think the pre-fitness exercise program is probably more important than without poles.
And then another question for you, Lynn. If someone was to sustain a knee injury, if it was a ligament or a meniscal injury, how long should they wait before presenting to a rehab professional?
Don't wait. Immediately. And some family doctors think you should wait until the swelling goes down. For physios, we absolutely want to see you right away. There's if you leave a swollen knee, it can get very stiff and delay your progress. If you're not doing the right things, you might just keep re-injuring your knee. So I wouldn't wait anytime. I would come in immediately. And we're happy to accommodate
Yeah.
people like that.
I'd love to reiterate that. One of the common scenarios we see is someone coming in at a month or two with a very stiff knee from a knee injury, and they've been afraid of the pain their knee causes. They've been afraid to straighten their knee, and they haven't been given the instruction to engage in motion. And so I couldn't be more strong in advocating early initiation of physiotherapy with a knee injury. That's just a given, and I think it still leaves all the options open. And you have to think of it this way: the body was designed to move, and even if injured, moving in its normal planes is health, and not moving is unhealthy for a joint.
Mark, another question for you. What are your determinants for surgery versus encouraging coping? And does this vary based on age or sport or sex or any of those things?
Yeah, so the question was, what are my determinations for giving guidance to whether to have surgery versus coping? And I would start with, how active are you? Are you a 20-day-a-year skier? Are you a 160-day-a-year skier? Are you 15 years old with 60 years of potential doing multiple twisting sports: soccer, badminton, ultimate, skiing, water skiing? So the more active you are, the more I go towards the surgical side. The more sedentary, the more recreational, 10, 20 days a year, maybe a brace is all I need, and I'm willing to slow down, and what I ski for is just being out there on a sunny day. Then it's all about how loose their knee is. If their knee is very unstable and pivots, even if you're a 20-day-a-year and you twist in the kitchen and your knee gives away, I'm likely going to recommend surgery. So a very loose knee versus a not so loose knee. It's uncanny how many people have gone and said, I have torn my ACL, I had an MRI that showed my ACL, and they come in and they say, but my knee feels good, I'm doing everything. Well, I might err to more coaching to the conservative side. Then I would also look at how stretchy they are. Are they double jointed or are they stiff? The more you're double jointed and stretchy, the more risk of re-injury. And so again, surgical. Age-wise, age isn't really a factor, because you can be a young 60, which I hope I am, or you can be an old 30 and you can be sedentary. And so it's not so much age, it's activity. So we have people in their 60s skiing 100 to 200 days a year, and they tear their ACL, and we're happy to reconstruct them because that's their passion, that's where their hearts are at. So honestly, it's multiple factors in the decision making, and those are the main ones I choose. But there are other more complicated ones, such as the shape of the tibia, the shape of the femur, other associated injuries in the knee. Do they have some collateral laxity? There's a bunch of other ones that do also go into the decision making, but I don't want to make this too complicated.
So Mark, we have a question from Mary, and she's asking, as a rehab professional, when do you recommend referring a patient back to their family doctor or onto a surgeon for surgical consideration? Are there specific rehab or functional markers that you as a surgical team look for?
Yeah, Lynn, why don't you start from the rehab side and answer? So the question is, from a rehab professional and from the rehab side, what are the triggers or the questions that would say, I think I'm comfortable sending you back to your family doctor versus I'd like an orthopedic referral?
Yeah, so like I said, we like to work with people immediately after they've had a knee injury and trying to work them through their injury and their goals. And when we're pretty high suspicion that they are requiring surgery, then we would, or at least wanting to discuss surgery, then we go on to send our patients to often a sport medicine doctor first, who that would then refer them to a surgeon. So there's a bit of a triage that happens. And
I might just comment a little bit about specialty namings and specialty labels. There are some family doctors that have a tremendous interest in sports medicine and sports injuries and are very competent at diagnosing and referral patterns. There are some that isn't their practice. They treat diabetes, they do new babies and obstetrics. Just as there are some orthopedic surgeons that specialize in sport injuries, there are some that put in hips and do spine surgery. So you do need to be a bit discerning of the label of your specialist. And everyone has their specialty. There are lawyers that specialize in crime, real estate, different parts of the law. Same in medicine. Unfortunately, the label can be the same. He's a doctor. Oh, he must know about ACLs. So I would tell anyone who's injured themselves to dig a little bit. And honestly, the sport physios are a really good spot to start. And the general practitioners who have decided to specialize in sports medicine are an excellent quarterback. And we use a team of 3 right now, and we use the ones from the city. They really have a good idea of when to steer you to the surgical route versus the bracing versus the coping. And so that's my little tip about where to search for expertise and help.
Yeah,
Anything more to add on that?
No, that's really important. And some GPs will just send directly sport physio because we deal a little bit more with that. But again, there's lots of GPs who really have a super interest, and especially in the Valley, because we all see a lot of knee injuries. So yeah, it's a good team.
Then 2 questions for you. One is, after a day of skiing, my knee will swell up mainly at the back, limiting movement. What do you suggest I do after a day skiing to prevent this and help reduce the swelling? And then another question as well on advice for getting the ability to fully straighten the knee after injury.
Okay, so what to do if you go skiing and your knee swells up? That is fairly common actually, because skiing is quite a hard sport on knees. So it's not always that we say don't ski if you're getting swelling, but if you are, a lot of the factors that we talked about earlier, make sure you have good fitness, that you're choosing runs that are within your capability, not skiing hard moguls all day. And it might just be doing too much in your knee. Or you might actually have pathology in your knee. Maybe you have a meniscus tear that's getting really flared up with skiing, and then we need to start going down the route of some physio and maybe getting possibly an MRI to diagnose it, or referring you on to a surgeon. Sometimes you need surgery. Swelling in the back of the knee can be a bit of a cyst that swells. And so having some physio, taking a little bit of anti-inflammatories, icing after you ski is important, and maybe not skiing 5 days in a row. Maybe you need to only ski 1 day and then take a rest.
I might add to that, a swollen knee or swelling in the back of the knee is some sign of something's wrong in the knee, and it's often some arthritis. To have a little bit of swelling and go home and do the rice recipe, get your leg elevated, ice it. Even some massage and some manual work can work on the knee. When you have the Baker cyst or the swelling in the back of the knee, it is still coming from the knee. The swelling is just going out the back, and that is a sign that the knee is irritated. Does it mean you can't go skiing again? No, but it does mean probably for that day you pushed the limit, and you might want to seek, is there something reversible or changeable? And that might include just a physiotherapy. Like it most often doesn't mean surgery in the knee. So yeah, the anti-inflammatories, the rest, the ice, the compression, all of those are tried and true, and I believe in them. I think that's a good way to manage them after a day skiing.
Mark, a question for you. What does it mean when a knee locks, especially falling in powder?
Okay, there's 2 most common types of locking. And one is one of the meniscal cartilages in the knee flips into the joint. And your knee is truly locked. You have to wiggle it or do something to unlock. And if it's happening skiing powder, it's because you're in a more flexed position. You have hurt your knee somewhere along the line, and most people remember hurting their knee. Now, the second kind of locking that is most common is when you have a little wear in your kneecap, and the kneecap bites, it grabs, and the pain is in the front of the knee. And that can happen in powder because you do sit back a little more to bring your ski tips up so you compress your kneecaps. That your knee is not truly stuck. It's locked, but it's not really. And you usually work the front of your knee and you massage your kneecap and it works itself out. That problem is dealt with the stretching, the strengthening, the core, all of those things, skiing the right amount, and the physiotherapy. The knee that locks and you can't unlock it until you get a huge pop, that usually means surgery. So that's the meniscal tear. But if you're grabbing the front of your knee, it's a non-surgical problem. If you're having to manipulate it and get a clunk, that's likely a surgical problem. Or there's a loose piece of bone in the knee. That would be the other thing. It's a really good question.
Mark, another question for you, whether or not you recommend knee injections and which ones?
There's a good role for knee injections, and there's a role for the whole gamut. You know, I believe in the exercise strengthening, weight loss, fitness, all of that is a given. But if you're still having troubles with your knee, there is cortisone injections, which everyone knows about. And they have a bit of ooh, I cannot use cortisone in my knee because this is bad for your knee. And I would agree, repeated cortisone injections aren't the way to maintain your knee and allow you to ski unless you're nearing a new knee. So if you know you're nearing a new knee, to do a year or two with cortisone is fine. But when I would use cortisone is in a crisis. Everything's going well, you haven't had a fall or anything, and you have a flare. There's a crisis. I know I've got a little arthritis in my knee, but it's not locking, it's sore and swollen. Cortisone is a good rescue medication. The other use I use for cortisone is when you do have something special. I'm going ski touring at Campbell Icefield for a week and I have some arthritis. I know I'm going to be miserable. Well, there might be a role for that special occasion. Cortisone is inexpensive, and if used sparingly, is a safe medication. We also have this new class of medications called viscosupplementation, which is lubricant in the knee. And the molecule is called hyaluronic acid, or you might have heard of HA. And kind of like cars, there's different brands. Synvisc, Durlane, Monovisc. There's a whole bunch of brands of cars. There's a whole bunch of brands of hyaluronic acid. That is a good molecule. It stimulates your body to produce more hyaluronic acid, more of its natural lubricant. It is an anti-inflammatory. It is an antioxidant. And general rule of thumb, in mild to moderate osteoarthritis, about 2/3 of patients respond well to that and tend to have an injection every 6 months or a year, up to every 3 months. But generally, you start with once a year, once every 6 months. So if you're a responder, it's a good thing to do just prior to ski season. We've got a list right now of injections to do. I will say that it's expensive and it does involve a needle. So those are the two negatives. About 1 in 20 will also get a reaction and their knee will blow up. That can be you're allergic to the medication, but it also can be a bad injection. The injection is injected into the fat pad. So there's the whole that. And then I'll just finish by saying there's a third option in Canada right now, which is called PRP, where they take your blood, spin it down, and inject it into the knee. And that has a similar or maybe slightly better efficacy than the hyaluronic acid. So I think that is another choice. And that would be, again, pre-ski season or a couple of times a year. Everyone asks about stem cells, and stem cells are now no longer legal to administer in Canada. And it's not because they don't have some role to play, it's just they haven't been researched. And we haven't figured out how to appropriately use them. And so right now, I don't think there's any research to suggest that you should fly to the States and have stem cells or go to Mexico and have stem cells. I think I would stay with the PRP. And I do think we're gonna see stem cells play a role in the future. We just have to learn, how do we really properly prepare them? How do we turn on the right molecules and make it work for us? But that's my spiel on injections, maybe a little lengthy. Are there any other questions out there?
One of the questions is, are any natural substances or supplements recommended?
Lynn, got any ideas on that?
Not my area of expertise, so.
Yeah. I don't know where you go, where you draw the line of what's natural and what's not, because everything we put in our body is a molecule. But there's some weak evidence that glucosamine and chondroitin sulfate can cause some pain relief, slightly better than placebo. I think just good nutrition and good hydration is the foundation for things. If you're happy rubbing some arnica on your knee after a day of skiing, I have no problems with that. I will agree with Lynn, this is out of my area of expertise, and I'm not negative against it at all. Just use common sense when you're thinking about using creams and oral medications. So I think I have to leave it at that for the natural approach, but I'm not against it.
And just one last question for you as well, Lynn. So for someone who's had a knee injury and is having difficulty straightening it, what are exercises to help with that?
After surgery or just an injury?
Just after an injury.
Okay, so someone's asking if they've had knee injury and they're having difficulty straightening their knee, and that is extremely common. It's that last kind of 5 to 10 degrees that they can't fully straighten. And physios have lots of different techniques to try to work on that. It might be swelling in the knee. It might be your capsule, so the tissues around your knee that it's kind of shrunken, that we need to stretch it and mobilize it. Maybe the muscles in the back of your knee are super, super tight. You might not have the strength in your quads to fully extend. So there's lots of reasons. So I'd recommend to see a physio and spend a few weeks working on it, trying all of our different techniques. We use some modalities, we use some acupuncture, some IMS and dry needling, so lots of different things to try. And there are some night splints that you can go, that can be custom made to your leg, and it pushes your knee down at night. That's one possibility. Or sometimes you need surgery because there is actually an arthrofibrosis problem, or you have a blocked meniscus, or meniscus that's blocking the knee. So there's a whole range of things to try, and we try with the most conservative first. And if we've tried everything, sometimes you need surgery.
Yeah, and just to add to that, losing your ability to extend is one of the first signs of getting some arthritis in the knee. And so that is common, and it is hard to maintain, but it is good to work on. So if you cannot straighten your knee, I would encourage, one, getting it worked up, but two, do work on it. You tend to limp if you have a bent knee, and that's hard on your back, it's hard on your spine. So I think working on knee extension is important. I've had my own personal experience when I had my ACL done. I took 18 months to get a fully straight knee again. And I had scar in the front of my knee and really need to work that scar. So I'm aware of loss of extension, and it's uncomfortable to straighten, but you have to work on it. Well, that's all the questions that we've had on chat. I want to thank everyone for participating in this. This has been a lot of fun, Lynn. I've had a lot of fun, and I want to thank Julianne and Sarah again for all of their help. And I hope people enjoyed the session. And hopefully next year we can do it live again. and get the mats out and everyone exercising together. So thank you for attending this session.
And if you have any more questions, feel free to email, what is it about?
BSM research at banffsportmed.ca.
There we go.
Okay.
Thank you.
Okay.
Have a good evening.
Thank you. Do your exercises.